The Healthy Home Lab is a real world testing ground designed to bridge the gap between clinical care and independent living. It's a laboratory for students to learn in a real life setting and a place that's open to community to understand the challenges, and a shared space where researchers and engineers work side by side to develop and to pilot smart home technologies. This 108-year-old home is located in Pittsburgh, Pennsylvania, a part of the country where 40% of the homes were built before 1940. This means steep stairs, high ceilings, and tiny cramped bathrooms are the norm, not the exception. This environmental barrier poses a significant challenge for the older adults hoping to stay in their homes and for the clinicians tasked with devising workarounds that are both effective and low cost. But not to worry, because today I'm excited to be joined by none other than Pam Toto, occupational therapist and director of the Healthy Home Lab, to help us explore solutions to these seemingly impossible environmental barriers. But first, a disclosure. Before we begin, we'd like to note that today's guest, Pam Toto, is the director of the Healthy Home Lab. While this episode will explore a range of technology solutions, we want to be transparent that one or more of the solutions discussed may be a product developed by the Healthy Home Lab. Our goal is to provide balanced educational content, and other product types and considerations will also be discussed. And now, back to our conversation. Welcome to Innovative Aging, a podcast for clinicians who want to stay creative, stay informed, and stay connected to what's possible. I'm your host, Carol Chiang, an occupational therapist with 27 years of experience in rehab and home-based care. I know how hard clinicians work to keep their clients aging safely, whether that means hacking together solutions, testing new products, or thinking 3 steps ahead. If you're passionate about helping your clients function better, but just don't have the time to keep up with all the latest solutions, this podcast is for you. On Innovative Aging, you'll hear practical, energizing conversations with experts in rehab, design, and innovation that can spark fresh ideas you can bring back to the people you serve. Together, we can rethink what it means to age well at home and lead the way in shaping the future of aging. Let's dive in. Hi, Pam. Welcome to the Innovative Aging Podcast. So excited you're joining us for our very first live event.
Thanks so much, Carol. I'm delighted to be here. I've really enjoyed sharing my knowledge through MedBridge in the past, through some more static opportunities than a live podcast. And I'm just really excited because not only do I get to share something that's really passionate to me, but I get to interact with you, Carol. And I'm a great fan and admirer of the work that you do in helping people to be able to age independently and safely in their homes and communities.
Oh, I love it. Well, you know as well as I do that nobody does this by themselves. This is a group project from beginning to end and everything in between. So, all right, I'm excited. I know tons of people are excited to hear from what you have to say, what is going on with the Healthy Home Lab. So we're going to just dive right in. Why don't you go ahead and tell us about your OT journey? Just tell us how you got into home modification and what does your day-to-day look like right now?
Sure, I'd love to do that. So I have to share with the audience that I've always had an interest in working with older adults. It's sort of even long before I knew that I wanted to become an occupational therapist. In fact, I started college planning to take the medicine route and really focus as a geriatrician. And I really was always interested in helping older adults really to be more independent and safe. And I thought that was the means to do it. So when I was able to find rehabilitation, which was a shorter route, and I think a way to make a greater impact, it kind of resonated with me immediately. Fun fact, my mom didn't even blink an eye when I said, "Mom, I don't want to be a doctor anymore. I want to be an occupational therapist." Back in the day when people didn't know what occupational therapists were. I decided I'm kind of a non-traditional researcher and professor. I practiced clinically for about 20 years. And to be honest with you, probably like many people in the audience, I was really frustrated with the pace that I was making an impact and change. I would work with one client at a time and be able to provide solutions for their needs. But I just felt like I wanted to make an impact on a larger scale. And I was frustrated that I knew there was a lot of great evidence and things that really can help people, but they were not being adopted in practice. So I decided that I would go back to school, pursue my PhD with the intent on being able to make larger scale solutions. It took a while for me to narrow my focus to community. My background with older adults really started in skilled nursing facilities, and I liked working in that setting and in congregate living. So it took a while for me to focus in this kind of preventative model and aging in place, and also focusing on compensatory and adaptive solutions such as tech. Um, for the past, for the, I guess, informally 4 years, but the past 3 years now as the director of the Healthy Home Lab at the University of Pittsburgh, I'm running an interprofessional lab in a 108-year-old house that's solely focused on implementing services and tech to help people age in place. So it's kind of been a long journey, but now I have the resources, the team, and the vision to be able to really put into practice those ideas that I had when I decided to take that leap from clinical practice into this other side of my role and job.
Your mom must be very excited at where you landed from that position.
She is, especially because she's also we're all aging, so she freely uses her daughter to maximize her own ability to age independently and successfully.
Okay, wait. I would also say it goes the other way. I bet she's great research too.
She sure is.
That's awesome. I love that. All right. So I want to just get us started with a little bit of statistics. I mean, why are we talking about this? We are aging in place people. So I want to just start with this statistic. So we know from AARP surveys, right? 90% of older adults want to age in place. That is a fact that we hear all the time, constantly. But the other side of that fact is that only 1% of all homes are fully wheelchair accessible, and less than 5% are even manageable for someone with a mobility device. This is just a gigantic gap. And a lot of times, what I tell people is if you just do the math, that less than 5% of homes in the US are accessible and 90% want to age at home, that's a lot of building. That's a lot of work that has to fill that gap. And something that's really interesting that I heard that the Home Depot CEO was actually talking about this massive opportunity on the horizon, given this information. So I'm curious if these statistics are something that maybe played a role in how the Healthy Home Lab got started.
Sure. So exactly it did, Carol. I believe that people have a right to age where they want to age. And I don't think that necessarily home means things to different people. So it's not about living in your same house, but it's about the memories, the activities, the habits, the things that people do. Sometimes leaving a home actually increases quality of life for people. I will not fight against that. But I do believe, given all the technology, all the solutions, the amazing advances we made in every way, shape, and form with technology, that if people want to stay in their homes, and we as healthcare professionals help guide them at the right time frame too, that they should have that right to make that choice. I really do believe that. And I think that as we age, I mean, if we all live long enough, we all have some natural declines. They're kind of badges of aging, right? Like our skin becomes thinner and our sensation might reduce. We need more light as we age. But I think that sometimes, people give us insurmountable goals and think that we're going to like create the fountain of youth or like keep people like perfect forever. We're not going to do that. I mean, but people are going to decline. We all have an end, a expiration date, but we don't know when that is. And so I think that, these statistics really show that given that combined with all of the solutions we have out there on the market, the way we live and date and work, that we should be able to provide those options to our clients.
Yeah, you make some really good points, which is that home doesn't necessarily mean your physical environment. Like it just means that where you call home, where is the space that you feel more comfortable, that I don't know. I want to just validate out what you're saying, that you can stay in a home or you can move to, let's say, your daughter's home, and that's still home. Like that's still a place where you feel safe. That doesn't mean that's not your home. So that's still aging in place to me. It's just in a different location. It's just somewhere else that you choose. And I think the most important thing that I heard you say is like, it's about the choice, about the control, about you as a person deciding that as I get older,
that this is what I want to do. And I feel like that is a major area where people are interested in how am I going to stay in charge of this? And that's why I'm interested in creating my home that fits me better.
Right. I do think, tied into that, Carol, is the idea that I think as rehabilitation professionals, especially in the United States, we're lucky because we're a reimbursable service, but it's usually triggered from an acute episode. And so we oftentimes touch our clients when they're in a post-acute stage. They're not their true selves. They might be way underneath. They might be fearful. They might have a lot of things going on. They might be in pain. And so people make a lot of big choices about home at those critical junctures. And with the work that we're doing at the Healthy Home Lab, and I'm happy to share more about it, but ideally we should be able to have these conversations with our clients before they're in that event. So in more of a when they're at risk would be a great time. And our research has actually found that when people are starting to decline but haven't had that injurious fall yet, or they haven't burned down half of their house with their stove because they have memory issues, that's really the time that if we could get in there, really make the best impact. And I'm hopeful that with some of the changes that keep happening involving in healthcare, I know we don't like some of them, but sometimes in some of these new accountable care organizations and different models, there are incentives for people like us, if we're ready, to be able to come in and make an impact, at those earlier stages when the older adult and their care partners are really not in a crisis.
Yeah. And I definitely am so curious about how this Healthy Home Labs got started, where the ideas come from. But I just want to back up for 1 second and touch upon what you just said. It's really about the PEO model, right? It is looking at that person, the environment, the occupation, and bringing that all together. So the OT lens, I've always thought, is we are the experts in the home because we're really good at modulating out those things. So if I can't change the person, well, let's change the environment. And if you're in a rental and I can't change the environment, well, guess what? I'm changing the occupation. I have to make an adjustment based on that. But we are sitting on this wonderful formula to help people be able to think about, okay, what are my choices and which of these are easier to do, which are higher in preference, which fits better with my lifestyle. So yeah, so please, I'm dying of curiosity here now. So I do want this whole backstory. How did the Healthy Home Lab get started?
So the University of Pittsburgh is in Pittsburgh, Pennsylvania, and our Healthy Home Lab really started as both a concept and a place. We're a level 1 academic research university, and there's a lot of people doing a lot of different work targeting this elusive concept of being able to age well. And so what happens sometimes is everyone's working really hard and is busy. And because we're so large, there's an opportunity that people are working on really similar things from different aspects without ever communicating with each other. You might go to a conference and find out that your peer at your same institution, is tackling that same challenge. And so we had some leadership that said, let's kind of get everyone together. And at the same time, it just so happens that there was a big, old, beautiful house on our campus that our university, quite frankly, was trying to buy to tear down to build student housing.
Oh, wow.
The same family had owned the home for over 100 years. They did not have students live in this house. They had always had family, and they just, quite frankly, didn't have the heart to sell it, to tear down. So for all of the audience, if you've ever seen the movie Up, we were kind of like the Up house in the city. We were a holdout. So the university built around the house. And so the family really was at a tipping point. And so we were looking for a house where we could kind of pull everyone together. And the family was delighted to have the opportunity for the university to acquire the home, with the idea that their home would be a test bed for us to understand challenges in a big old house with 14-plus-foot ceilings and pocket doors and radiator heating and steep stairs and a low toilet and a small bathroom, and really be able to start tackling some of those problems. So that happened in 2022. When we started, we really, it was dominated by our research team and engineers, and they kind of saw it as a house where they would just kind of play and create stuff, if you will. And they had a big mobile toolbox in the middle of the dining room. And what was nice, again, it's just a testament when you bring interprofessional together, you bring medicine, occupational therapy, physical therapy, social work, engineers. We started looking at the greater possibility of the Healthy Home Lab. I did naturally, and I thought, if we're going to do this, let's really maximize what the house can offer. So we turned the house into a home. And actually that first step was part of some of our Doctor of Occupational Therapy students' individual capstone projects. We gave them a budget and we furnished the living room and the dining room and the kitchen and a bedroom and a bathroom. And we wanted to make it look like a real home. So we have smart technology that we've added, but we're not a smart home, we're a real home. We have couches that are low. We have a coffee table. We have an area rug. And people say, how can you have this here? Because if we don't show the problems and what people are willing to accept, then how do we show the solutions? So that really shifted our focus. And it also gave us an opportunity to be an education site. And so we offer the opportunity for any program on campus, including dietetics, nutrition, information management, whatever it is. Anyone who thinks that they can learn and elevate their students' understanding of what home means to people and why they're willing to accept risk or why they're willing to limit themselves or why shouldn't they limit themselves. We allow those students to test in our home. So the School of Medicine tests in our home. Emergency medicine actually trains what they can look for in our home.
And getting up and down those stairs, like with your stretchers.
Yes.
Oh my gosh.
We even have a recent group from like the cardiac arrest study, investigating how, if an older adult is with another older adult, like how can they use the same mechanisms and standards that we're trained to do CPR, and how can you modify that in a real home? What are the opportunities and what are the barriers? So those are some of the education things we do. And then we also offer opportunities for the community to come in. And we don't train people, older adults, how to do things in our lab, because our lab is not their home. What we do is we set things up and we ask these older adults to be kind of our information sources, and we co-design with them. What do they like? What don't they like? What are we getting right? What are we not getting right? And then the last phase of all of that is we work with these community partners, agencies like the Area Agency on Aging, Southwestern Pennsylvania Partnership on Aging, Age Friendly Greater Pittsburgh, to deploy some of these technologies and these services into people's homes in the community. Because if we don't do that, I'm an implementation researcher. If we don't get what we're learning in the lab out to the people who need it most, then we're just a cool looking lab.
Right. I absolutely agree. There's so many things that you said there that are fascinating. So first of all, I love that everybody, all these different departments are hanging out in the home and saying, hey, like, I want to try this and see. I'm curious, are they doing that in groups together? So like one of the biggest opportunities that I heard you say was learning to work with a different profession while you're in school so that you break down those silos before you go out into the community and get frustrated that I said one thing and then somebody else told you the opposite and we didn't work together to do this together. So I'm wondering if there's like, you're starting the collaborative journey in their brain early as a student. And I'm just wondering if other disciplines are also doing that. Like I heard you say medicine and dietetics and stuff, but I could see lots of great overlap in those.
So one of the exciting things about what we're doing is that the world needs us to do what we're doing. So everyone's listening, because we need as a society for people to be able to continue to do more things a little longer for themselves and to do them safely and independently.
Yeah.
So whether you're a healthcare system, whether you're a consumer, whether you're an older adult, we need these solutions. So, but we all know that there's different levels of willingness to accept change, right? So, so even in academic institutions, some educators are more innovative, and some are more less likely to be able to want to try to make it work. So we have had a variety of students and a variety of programs and a variety of professors who have initiated either single professions or working with other professions. The challenge to that is, again, the willingness to be creative and to change out of your normal zones. Like, we have class on Tuesdays at 10, but emergency medicine can't come until Wednesday at 4. Someone's got to give, right? If you want to make that work. And so what we do is we put the opportunity out for whoever wants to be part of us. And it quickly rises to the surface of who really is innovative enough or an early adopter to be able to kind of change the way that the way they've always done things to enrich the experience for the student, and people who are less willing to do that. I will share that the School of Medicine here at the University of Pittsburgh operates a place called the Hub. And in the Hub, pharmacy students, dentistry students, nursing students, and medicine all rotate through that Hub. And so they've actually taken, while students are at the Hub, and have built in a training session in our lab. So we've had over 100, I think 180 students from those different disciplines. And they start with a case story and the team, but they're faculty. These are physicians. These are people who practice clinically and also teach. They bring this, they bring their props in, they bring the case stories in, and they lead it. That's the one thing that we don't have enough. The lab is still evolving. So we have a small core team. But we like, if we had a education grant, for instance, we could hire someone who's kind of delivering this full time. But right now it's kind of on a case by case basis. If the program is willing to partner with us, I will share since you did ask that, is our School of Health and Rehab Sciences, which has, over 15 programs in our school, was able to be was able to develop an interprofessional aging in place training for all students within our school. It was not mandatory. It was if you volunteered, and you could get a certificate and a badge for going through the online training. But there was also an aspect in the lab, so it gives students who wanted a chance to be able to learn with other students.
Yeah, I love that. And what you're doing for all these physician faculty guys is just giving them context. And everybody learns better with context. I think that's just fascinating.
Well, I want to jump in if I can before.
Yeah, please.
One more thing. So one of the things that I like to talk about is the dining room, and hopefully this resonates with everyone on this call. So, a lot of our medical folks who come in and mostly they don't work in people's homes, and I'm like, so when this older adult is in the hospital, and you tell them they have to do X, Y, and Z in order to go home, I said, they're going to say yes, but they're lying to you.
Yes.
You have all the power, and you won't approve their discharge unless they agree. I say, but when you tell them, oh, your stairs are steep, we'll put a bed and a bedside commode in your big dining room and you'll be set. And I say, but once someone gets home, all of us would put up with that for a short while, but nobody wants to sleep and go to the bathroom in the room where they serve Thanksgiving dinner for 50 years. And so what happens is once someone gets home and they're out of the eye of the acute care medical system, they go on to solution wasn't really a long-term solution. It was just to get out of jail or get out of a hospital.
It was a checkbox.
That's what I tell the physicians. I'm like, they're lying to you. Nobody's going to do this forever. So
that's because we know better. The physicians have the ideas. Oh, they're probably going to do it. And we actually been in the home and we're watching when they're rolling up unrolling the rugs that have all been put away. And they're like, okay, now I'm putting my house back in order after everybody else tore it apart. So I visited the Healthy Home Lab myself, in 2023. And one of the things I love the most was seeing all these educational posters, right? Because it broke down all those real world challenges that you guys are actively trying to solve when you're trying to navigate a house like this. So I'm really curious because that education part seems really important to me, the education of the community. And when you talked about how the community comes in, I feel like what hopefully is happening is that they're inspired by all of these things that you're showing them, and none of them involve ripping the house down and creating a sterile hospital space, because anybody can do that. But the hard part is being creative and managing, keeping the history part of it, keeping the beauty part of it, right, but still solving these issues. So yeah, can you just talk more about how the lab really interacts with their community members, and what is that feedback? What do you hear back from the community?
Sure. So I think for everyone who's joining us today, the truth is that we're a very ageist society, and we're very medical model focused and deficit focused. And our clients, people don't want to spend the rest of their life thinking about all the things that are wrong with them. They want to think about all the great things that they can still remain doing. And so first of all, our lab really is not a very medical model. We focus on, we're a strength-based model. So we say, okay, you have these conditions or diagnoses, but what are the strengths that you bring? How can we capitalize on where you are now? Maybe you're maybe your cognition is really sharp or your vision is good, even though your mobility is bad. And so we do that first. And we really, I think that our visitors and our community partners are pleasantly surprised because they're so used to the healthcare system telling them what's wrong, you know? So that's number one. Number two is our research has really found that older adults in large part are willing to use and embrace technology if it meets their needs, the things that they want to do, which is really important, right? So it's a very person-centered approach. Right now, there's a lot of technology that's on health monitoring, and that's what health plans want and medical systems. But you know, like my own mom isn't interested as in someone remotely monitoring her blood pressure as she is making sure she can still use her Facebook because that's how she kind of, you know, interacts with her friends. And so that's the next piece is I think that if you think that your client can't use technology, then you'll kind of fail at it. So you have to believe that they might, but you have to figure out what's meaningful to them. And also we know from our work at the lab that older adults can use technology, okay, but their self-efficacy is much lower than younger people. Right. So one-time fail and they're like, I'm a dummy, I'm too old for this. So sometimes what we do is we really try to find out what would appeal to the older adult. And we think that, again, taking that strength. And then I might recommend something that product A might be the best product on the market, but product B is easier to use. Yeah. And if this person really has low confidence, I might choose product B if it still meets their needs because I'm kind of listening to them and I want them to have success. We should also be talking about the fact that all of our technology breaks down sometimes. So we have to also teach the consumer that is going to happen and kind of what should they do when that happens and who's going to take over. If we're a clinician coming in for 3 visits as part of home health or what have you, you're not going to be there forever. And you're probably not going to want, even though you might have given your cell phone to your client, you probably don't want all of your clients calling you forever. Hey, Carol, you know, I had an iOS update and now Alexa won't answer me. So I think that those are all important pieces. Yeah. If a client doesn't want something, we're certainly going to kind of think about a different way to approach solving their problems.
Well, and luckily that's clinical reasoning right there. I mean, you're looking for the just right challenge. If it's too hard, they're not going to keep it. It's not going to be long-term. If you can drop it down a couple notches, we're good. So assessing tech readiness is a huge part in that. And I think you're absolutely right that older adults don't care necessarily about their health and stuff. What I find is that they really care about how it looks. And so I think that matters. And it's a mistake to be pushing that under the rug and saying, oh, like, that's just a luxury. You know, you need to do the things that are important for you. Blood pressure, your pulse, your diabetes, you're missing part of the picture if you don't address that part, because that is the motivation to kickstart people into accepting other things, because it's a feed forward process, right? Like you start exercising, you feel better, you exercise more. So you hope that home modification or whatever, thinking about your future would be a little bit addictive, I would hope. So I want to switch gears a little bit, because what's really neat is the Healthy Home Lab's not just identifying these problems through research, you're actually building solutions too. So can you talk a little bit about these challenges, developing some, products that can help with, solving those issues that you see in the home, and, what are those hurdles that you got into as you were looking through different iterations?
Sure. So I come from a skilled nursing facility and home health background before I transitioned into this work. And as a clinician, you're usually looking for the cheapest, easiest, low cost solution that's out there, much to the chagrin of my engineering colleagues. So they're like, what? You want a $30 bed bar and not something more elaborate? I'm like, yes. So whenever possible, we're not trying to replace everything and make someone have a high-tech home. We're just trying to look for the gaps. And sometimes there are friction points for us as clinicians. I know myself, when I was practicing in home health, I would have a client who needs a grab bar, and with a grab bar, they could achieve the goal that we set for them to bathe independently. but they have no one to install a grab bar, or like they could purchase a grab bar. And so then you're caught with a wall mounted grab bar would be ideal, but maybe you purchase one that's a tub mounted grab bar because it's one that you could install and get more easily. And you have to see that person twice a week, or you only have 6 visits and they're going to close out the case and you still haven't had that grab bar installed. So our team listens to clinicians, not just consumers, but listens to clinicians. And one of the topics that was grab bars. And so our team really learned from occupational therapists and physical therapists about how you want a grab bar in place A, but you need to put it in the studs, or people have tub showers that have surround in them, so you can't easily install a wall mounted grab bar in a surround. So those 2 examples have actually led to some products that we've developed internally. One is a product right now, it's called Mobius, and it's close to commercialization. And essentially it looks like a chair rail, but there's a metal railing that is mounted on the wall along the studs. And what it does is it allows you to cover it up with a beautiful chair rail, so it doesn't look very institutional, but you can pop pieces of the chair rail off, if you will, and pop a grab bar on. So it holds 250 pounds of pressure. So essentially you could put a grab bar anywhere along there, not where the studs are. And the person can be supported in terms of mobility and their independence. They originally thought they'd put it in a whole house. I thought that was a dumb idea, if I'm going to be honest. And I told them maybe, but I do think it's great for rental properties or like congregate housing. I've been in senior high-rise apartment once where a gentleman had 9 grab bars in his bathroom, and it was from each person who was before him. They just didn't take it out. So like, it kind of looked, rather funky, and he didn't need 9 grab bars. But this would be a way that a facility could actually pop it in, pop it out without needing a handy person every time. And also you could reuse the grab bars. Another product that we're working on is a product called Shower Steady. And right now through our Medicare, Medicaid programs, when someone does have a tub shower and they need a grab bar installed, sometimes the first solution is to rip out the whole entire tub shower and put a walk-in shower, which we think is a high cost because you can't install a grab bar and surround.
Right.
So our team was able to leverage the Mobius and sort of build like a modular tension mounted system, if you will. So if anyone on this audience has ever seen a super pole, or like almost like using a tension mounted system, that you could install a temporary bar system into a tub shower that would kind of bypass that problem of having a surround system that you couldn't put it in for a fraction of the cost of ripping out a whole new walk-in shower. And more importantly, you can take it out when the person's done and it can go back to being a tub shower, or it could be reused. So those are just 2 examples of products that we're developing. I will tell everyone here who has an inventor in their heart or is entrepreneur is that it's a tough business and it takes a lot more hours and a lot more money than you think. So we only proceed cautiously with our own products when we really see that there's a gap in the market and there's nothing that exists, and we can kind of make things better for people to age in place.
Yeah. And you have to know your audience. And luckily you guys know your audience, know it really well, so well that you've identified the gap yourself. Right. So you talked about the grab bar, the tub, and the other big eyesore, with home modification, stairs. So, that's just a huge barrier. And, the steep ones that you're talking about in homes like that, what is it, 3 stories, 4 stories? I mean, that's really crazy. So I'm just wondering, like, walk me through that clinical rationale about integrating like robotic assists like RailBot, and like how does a healthy home lab test these things for real world usability? What does that look like?
Sure. So I'm sure many people on this call could empathize. So stairs really do present a mobility barrier. And currently right now, we either have the choice of someone going up the stairs, either unsafely, struggling with pain, up on their backside, whatever it is, basically eliminating the use of their basement or their second floor and just turning a home that's not designed to be one floor living into a living, and having to be okay with having your bedroom and your dining room and a bedside commode. Because I think I forgot to mention that most houses in Pittsburgh all only have one bathroom and it's on the second floor. So that's even a bigger issue than the bedroom, or getting a stair lift. And really, what we know from our research in the Healthy Home Lab is that there's been no real change in stair assist mobility for over 30 years. I mean, it's still the same. The same three choices are just about it. In other countries, in Europe and other places, they have tried to create some different designs, but they haven't really worked well in the United States, especially for steep stairs. And so our team has really been interested in looking at technologies. You mentioned a product called Railbot, and Railbot was a preliminary rail stair assist device that you could mount and still walk and hold on to it. It was created actually at the University of Alabama, and that investigator transferred to the University of Pittsburgh. Where we reached some gaps are in terms of who owns the IP. So there's also this whole who owns when you come up with an invention, and how do you move it forward. Turns out Alabama, we weren't able to reach an agreement in that regard. But more importantly, that device was really expensive for us to produce, and so why would we spend a lot of time, money, and energy on creating something that wouldn't be affordable to the general public? And so that has really shifted our thinking. We've had a couple of failures. Our engineers came up with a solution of, if you think of a tow rope in skiing, they thought that maybe a rope that kind of is like almost like the hand part of the escalator, but it was a rope, that maybe that could be a solution. And they tried it in a lab that was not our Healthy Home Lab. And it kind of was okay. It was like 7 steps. And then they brought it to our 15 steep stairs. And every clinician, including myself, was horrified. We're like, what? Like, are we going to pull an older adult up the stairs? What if they stop? Is it going to pull them down the stairs? So the house was we call it a learning lesson, but it really showed that, a real house with real problems kind of gets you to the solution a lot quicker, or to give up. Instead of, we could have spent 5 years and got a grant to explore that further, and really came to the same conclusion that like 3 days in the Healthy Home Lab told us. So we have several pending grants on the topic right now. For all of you on the call who work with clients in the home, there's a really interesting dynamic happening right now. Anecdotally, you might all agree with me, is that some people, we believe that stair lifts increase life space, and they do, because it gives you more access. But there's also a belief that they also contribute to your disability, to your decline, because you're not using your large muscles to actually walk up and down the stairs. And so there's some different schools of thought, even by individual consumers, where they have a stair lift, but they choose not to use it because they don't want to, make their leg muscles weaker. And then there's other people that believe it's the be all end all and it increases life space. And other people use it for their cat or for their laundry basket. And there's really no science behind that. We're trying to tackle it from couple different angles, because I think that, getting a $3,000 stair lift to take your laundry up and down, or your groceries, yes, it allows that person to live well, but is that the best we can come up with? So we're trying to come up with some alternate devices, the next generation, and also to be able to uncover some of the reasons why people do and don't use them, and really what is true. Like, is it contributing to my frailty, or is it really giving me better life space? And when should we kind of tilt one way or another?
And all of those things have nuances, right? I mean, yes, if you think about this 30 years before, that you are deliberately using your 3-story house to be your indoor gym, then you probably can. It probably will contribute to your quad strength, and you won't need a stair lift at that moment. And the problem I have with stair lifts also is that you still have issues of how do I get to the seat, and then am I going to have a walker at the top, a walker at the bottom? It's different for every person. So I think it is really important to have all of these different ideas, but also the intentionality of thinking, like, why are we doing this? So we're going to take a little break right now. We've talked about a lot of stuff. We want to look at the Q&As, lots and lots of Q&As coming in. So I just want to get out a little bit. Let's pull out some questions here, Pam, put you on the hot seat.
Sure.
So there's a really interesting, comment here, and it's just about, like, where do you find information? Like, is there a book, a resource? Like, where do you go to find these networks and people that somebody can learn about if they want to get into this space? What do you think about that?
That's a good question. I hate to say this, but I think books are so dated. This material is coming out so quickly. So I think that being part of I guess it depends. So you can be part of your professional associations. There's some great ways to find out about new products or new innovative things that people are doing, and also to network. So finding other like-minded people in your profession or in your region is one way to learn about new things. There are a lot of different organizations out there. They might be local or regional. The AARP has an age tech hub. There are some age tech groups that are out there. And some of those people are also vendors. So it's just a way to be able to get out and learn. But it's kind of non-traditional, I would say. It's like not where we've always gone for rehab in the past. I had the opportunity to go to the Consumer Electronics Show this year, as I know Carol did as well. And I never planned to go there in my life. I thought, why would I go there? What is that going to give me? But the products that are coming out on the market, or things that are really not necessarily designed for people who we would consider rehab folks, but I still see the benefits. So I think those are some pieces. There are certifications you can sometimes pursue, like a certified aging in place specialist certification or a certificate in home modifications. I don't know that they always provide the smart tech angle to those pieces. So I guess so a good starting point would be your professional association and then some regional organizations. Here in Pittsburgh, we have several different regional and also some state tech groups that really are great resources to kind of get started. So that's, I guess, a starting point.
Yeah, no, and I totally agree with you. I think my first way that I found this was connecting with those state assistive technology groups where you can borrow technology to try and see. So every state has one. You just have to look it up. We can put the link in the show notes later, but check that out. Get to know those people. Find out like what kind of tech that they might have there. A lot of times those are disability focused. They may not necessarily be aging in place, but you're just trying to absorb as much information as possible from whatever sources you can. So, connecting with.
Just to add one piece, Carol, too, is that one of the things about the Healthy Home Lab, and I think this is important, is that aging into disability is not the same as aging with a disability.
Right.
And I'm really an expert into aging into disability. That's where I've started. That's where I've grown my knowledge. And we know that there is some overlap, but they don't want it. They're not the same group, and they don't want to be treated the same way. And so I think sometimes when I get involved with some of the tech groups in my region here, I have to make it really clear, because they are really experts in aging with a disability, and that's who their focus is. It might be people who have an intellectual disability who are younger adults, or people who are 25 and have a spinal cord injury, and there's overlap and we can share resources, but sometimes the technology that they're seeking is just more or different than what I need. There's a couple of great models of that too, and the work came out of Georgia Tech, and I want to say UIC. Wendy Rogers and Sarah Saja and John Sanford. And there's some real good ways to think about that. And if you are interested in older adults, that might be a way for you to actually get your footprint into those agencies, because they are very good at aging with a disability, but you may be the expert in working with older adults aging into disability. So don't underestimate yourself. It's kind of more of a niche market, I think.
Yeah. Yeah. I mean, I think when people ask me this question, I just say, look, the certifications are like when you go get your OT degree. You go through the classes, you have your traditional things, you learn the basics. This is how big the normal structures are, the studs are between, but that's not always average. It's just giving you this kind of baseline, but the real learning happens when we go to do clinical rotations, right? Don't you feel like you learn tons more in those times when you get out and do it and you try it and you start hammering at your mom's house. you ask your neighbor, can I assess this space and take a look and see how you function, right? Like we're doing what clinicians do. We're looking at it and we're coming up with ideas. I don't know if you have anything else to add with that. I just wanted to grab another question before we move on. There's a couple questions about the Mobius, and they're just interested about more information on this movable grab bar that it pops in and out. And one of the things when you were talking about it, I thought, man, this is like totally spy tech. I'd be selling this like, guess what's behind this wall back here. So, where can people find more information about that?
So it's close, but not ready for retail.
Okay, got it.
So it's not ready quite yet. It's actually in production, and that's also, I'm an occupational therapist. I'm not I'm a businesswoman, but I don't mass produce products, but you learn a lot about those kind of things. So I would say probably within the next year, hopefully within this year, it'll be there at the end. And in the extra materials, we will also be sharing the Healthy Home Labs website. So we do have posts and updates on our website too. So we can that's another way that you can find out when we're ready for prime time and when you can acquire it.
Awesome. So I'm going to take one last question. That was just, do you know of other universities that have a similar type of program?
So universities are popping up all over the place with different types of programs, and I'm not familiar with another university that has an old home like we do.
Okay.
But I know, for instance, I'm working with a team at the University of Texas Medical Branch, UTMB, and they have really embraced this. They actually came to our Healthy Home Lab and kind of took a look at some of the things that we have, and they're creating their own showcase model to be able to demonstrate technology. They just don't have an old home that they're doing it in. So that's one example. But there are, but it's an opportunity everywhere.
Absolutely. And I was just going to say, well, you know what? We have Healthy Home Lab as an inspiration. So let's find out. All right. So let's get back to a couple of the questions. I have so many still, and we are already running out of time, Pam. I don't know how this happens. We end up just talking and talking. So we talked a lot about this educator part in this, and I'm just wondering, like, when you're teaching students about aging in place, like, what is it that you tell people? Where do they start? So we talked a little bit about the certification things, but you're also a professor. Where do you start with telling them, and what do you tell them are non-negotiables in that assessment process?
So there are a couple different things that I want to share with people in the audience, and I want you to think about your own practice, because we all have different comfort levels of how we approach the care that we provide with our clients. So as an educator, I teach my students that they should drive the assessment really based on what their client wants, needs, and is expected to do or to remain in their home. And a lot of times, to be able to, I will usually bring props with me. I want to give someone something on that first day because I want to build their confidence in me and their trust. We even when we think about health literacy and we think that we get rid of the jargon, we still talk about a lot of jargon, or we're at someone's house for an hour and a half and we're like, okay, you should be excited for the next time I come, but I'm not going to give you anything today. So I usually try to give someone, whether, it could be something simple. It could be putting a little gadget on their walker that allows them to carry their cane, their reacher with them everywhere. I usually try to do something like that. But I do think driving the assessment based on what the client wants and needs to do, and maybe if you can actually pick the wants goal over the expected goal, if it's not critical, it'll really build their trust in you. I also think about a positive versus a negative approach to assessment. Again, I said we're an ageist society. I tell my clients I'm the best chance you have. I'm your best champion to keep you in your home for the rest of your life. And then I try to live up to that. So instead of saying, oh, if you don't do this, you're going to fall and break your neck. Like, that's just not the way to reach them and to gain that trust. So that's the second piece. So drive the assessment based on what the client wants and needs and is expected to do. Positive versus negative approach to assessment. I really do use a person, environment, occupation approach. So I drive my interventions based on the older adult's capacity and also their readiness to change. So if someone has the capacity to get stronger, for instance, or to have better balance, or to improve their cognitive skills or their fine motor skills, and they want to, and I can do that, I can help them get better. But if they don't have the capacity, their body, they have macular degeneration that's not going to get any better. I mean, we're not going to, or they don't want this is like their 10th time they've had a therapist. They're like, I never do the exercise program that you give me. Then I shift to more of a compensatory or adaptive approach. So I like I like to break those out. I think of compensation that the person still has to learn. So maybe they have to learn to get dressed sitting versus standing, or how to use a shower chair. But I also could sometimes, if the person really doesn't want to do anything, they are cognitively impaired, I can also change the environment. I can increase the lighting. I can put risers on the bottom of their couch and make it easier for them to sit down and get up. And they don't even know that I did it. Like, I mean, I will tell them, but, so I can make passive environment changes, or I can make more active changes that are more compensatory in nature, building on the person's strengths. So those are all things that I try to do. The last thing that I'll say on that, Carol, is at the end of the day, sometimes independence and safe are not always congruent. We want to shoot for both, but sometimes there's a risk factor there. And personally, I believe that an older adult who's cognitively intact has the right to self-determination. I'll work as long as I can. But if they wish to be independent and have a little bit of risk, they're my client, and that's who I'm going to work with. If you are worried and you're always thinking safe, then I think this is a tough market to tackle, because it might be what you think they need to do, or what their care partner thinks that they should do, but it's not really what the older adult wants. So I think you have to also measure your own comfort level and where you're going to lean on that scale.
Yeah, there was an excellent AOTA presentation all about that self-determination, the idea that you should be allowed to take those risks. Yes, every day we get in a car, we're accepting the risk. Every day we do whatever, we accept risk. So people should also be allowed to take whatever risks that they have. And I think that's an excellent nugget of advice about getting people, just giving them something, get them to trust you right away, build the relationship first. We don't want to be thinking about, we're doing this to you. We want them to be empowered and show them, here are some little tips and tricks that we as clinicians use. And, they seem small, but let's check back a week from now, and maybe you're going to find that that's a lot easier. And if you like that, we got more. There's more that we know. So, all right. Well, we are getting close to time over here, and we have not even talked about the most important thing, which is money. So I'm going to ask those difficult questions, right? About what happens. Like, people might be totally fine with adoption, but then what happens if they don't have the money to cover those home modifications? So tell me a little bit more about how Healthy Home Lab has approached this conversation. Like, you must hear that from community members who come in and say, this is really cool, but ... How do you answer that?
I think there's kind of a multifaceted answer to that. So first, what I want to say is that in my clinical practice, I underestimated people's resourcefulness when they really saw the value of what I was providing them. And a great example would be, I worked with a woman who needed a stair lift, and she was very low income in a low income set community, and she couldn't get out of her home without it. And I called in every person I knew, every nonprofit agency, every foundation, because I didn't know how she was going to get that stair lift. And I was really coming up short. And so I went to her home dejected, telling her I hadn't found a way to get her one. And she said, honey, they're bringing it on tomorrow. I'm like, they're bringing what? She's like, I got a stair lift. And I was like, what? You did? And I said, how did you do that? She said, I worked it out. She said, I need this. I can't live here without it. I figured out a way. I'm going to make some payments. It might take a while, but I've got this. So my first piece is that if the client if it's really valuable, don't underestimate your client. I mean, I work with clients who don't have limited resources, but if it's important, it's important. Think about that Taylor Swift ticket that you thought you couldn't afford, but you bought anyway. So that's number one. Number two is know your region, know the resources in your region, and if you're going to plan this pool, and also know your state rules. So I live in Pennsylvania, and Pennsylvania actually has a little known $25,000 per person home modification option. It has some strings and hoops, and it's clunky, and you have to apply, and you might not get all the money. You might go in not knowing. But like it is an option. Working with your state, like the Department of Aging, they might also have like grants, or they might be putting some things in. So getting yourself on the forefront. I could talk about the state of New York that the Department of Aging has done a lot with technology. If you're a clinician working in that state and you know that your state is trialing those products, put your name on the list. Say, hey, call me when you're, offering this new technology for free to people in their homes, and so that you have that access. The other piece of that I would say is there are nonprofit organizations who can sometimes provide those. And then last but not least, make sure you're measuring the outcomes and you're having to ask to your health plans. In Pennsylvania, where I live, a lot of clients are on Medicare Advantage plans. And so that allows me to work with a health plan that might have a little bit of wiggle room because they get paid kind of differently than a straight Medicare or Medicaid, that we could maybe not offer $2,000 worth of home modifications, but maybe if I can demonstrate the value that a $500 Alexa could really save them on personal care attendance, because that could actually provide the prompt. Instead of bringing a person in the home 5 days a week, they can get away with 2 days a week. So if you don't know how to do that and measure those outcomes, I would say then reach out to your local universities, because they should be able to help you. But we have to measure outcomes that matter to the payer, and we don't always do that.
That's a really, really good point. Instead of looking at it like shopping, we need to look at this on a bigger scale and think, how do we convince them to see the value that we already know from research, and advocate for that, advocate for those people. This has been amazing. So I just want to bring everything full circle. We've talked about 10,000 things. What would you say your top 3 takeaways are for clinicians? Can you give me like a little idea on this?
Yes. So okay, I'm going to shout them from the rooftop. Number 1, solutions do exist. Okay. There are a lot of solutions out there, and every day there's more. Some of them are not good. This is where your clinical eye is imperative. Okay. I don't care what infomercial they say, it might not really work. So it's really your job to be current on available solutions as much as possible, and to offer them to your clients. You are the conduit. You are the trust factor. You don't have to do it alone, but especially if you're seeing something over and over and over again, you don't have to know all the solutions, but they do exist. And reach out to your partners if you don't know them. I think that if this is our business, we have to provide best care. That's number 1. Number 2, we have found time and time again, even though this is challenging, intervene early to extend what your clients can do for themselves. So I've had to have the opportunity to implement a lot of different interventions, but over and over, time and again, if someone already has a do-for service, like an aid, they won't give up that aid, even if I can get them independent. So let's say I see a client who needs help with bathing, and with some home modifications and some training, I can get them independent again. If they have an aide that comes in and bathes them, they will not give that aide up. So I think that our opportunity right now, there are waiting lists for do-for services, for Meals on Wheels, for a care attendant. So if we could get in now, before that care attendant is already assigned, that's our opportunity, and you could make the biggest impact. Once they have those do-for services and they've given up their washer and dryer, how are you going to teach them to do their own laundry again when like someone's already unplugged it? And the third piece would be to consider readiness for change and capacity when you're deciding on which person, environment, or occupation focused solution. We use more than one, right? We combine those, but the one that you're going to focus on, I feel like, as clinicians, we always focus on an exercise program. And I'm an exerciser. My research is on exercise. I love to exercise. Don't mistake it. But like, if someone needs to get on and off their toilet today, even if they are compliant with your program, they may not get strong enough for 4 to 6 weeks. How are they going to get off the toilet today? So I think we really have to think about, what is the client willing to do to meet us? Earlier in my career, I always blamed myself, like if we didn't achieve a goal. And I think that that's not true. These are human beings that we're touching, but they have to be in the game too. So you have to figure out what they're willing to do, and then matching that with your approach. And luckily we have all 3 solutions, right? We can make the person better, we can change the way they do their occupation, or we can make the environment more friendly and have less barriers. So those are my 3.
I love that. And I think that's really a great, it's a great point to think about, that it's not all or nothing. It's not grab bar or no grab bar, or no toilet, no elevated toilet seat or not. It's a graded activity that you get stronger and stronger until maybe, hopefully, you don't need it anymore. So maybe that is the motivation to somebody.
Right.
All right, Pam, 8:00 already. We are at a point where we are going to take some more questions. I see here a very good question about smart home technology, meaning what do you feel like the best smart home technologies are that have made the biggest impact in, some of the clients that you've seen?
Well, that's a good question. So I will say this, the Healthy Home Lab is product agnostic. So we don't really, we're not Consumer Reports of smart technology for aging. I just want to say that we won't be that, because I think that every home is different and every person is different. So our big old home, some technologies don't work as well there because we have big walls and ceilings and thick walls. So with that, I will say two pieces. One is if someone does have the internet, which I think everyone needs it now, like that's a different story, but like it's like the right, usually we should have the right to healthcare and we should have the right to internet. If someone does have internet access, I think that some of the apps that allow you to set up routines, we've had a lot of success with Amazon Alexa. And we've also tried Google products, and Google's fine too. But the one difference, at least right now, between Amazon and Google is that Amazon is, I would say, trilingual, whatever, multilingual. It will allow you to use apps that are not Amazon products. And like to date, more of the Google has been more that you have to continue to go with all the Google products. So if I'm really kind of piecemealing some routines and some smart technologies together in our lab, Amazon and Alexa has been a better match. It's allowed us to have smart locks, to be able to build routines, and that takes me to my part B. So that's my second part of the question. I think if there's one thing we can do for consumers, it's to increase lighting in their homes. So this is not just me. There's been a lot of great research that's really demonstrated we all need more light as we age. We should not feel guilty or bad about that. We all need it. And we know that better lighting reduces falls, lets people know that their food's spoiled, lets them know that their clothes are dirty, lets them see that they dropped a pill on the floor. And so we can increase lighting through some of the smart technologies. But even if someone doesn't have internet, there are just some great products that are on the market, even like lights, night lights that you never need a bulb for. You just plug into the outlet, and when it's dark, they turn on automatically. No one has to turn them on or off. So I would say that those are the two factors. If you do have the internet, maybe an Alexa that allows you to set up several routines with lighting, or if someone doesn't have the internet, to still be able to try to tackle improved lighting.
Yeah, I completely agree with you. Lighting is the single easiest thing to do, even if it's a $10 plug-in night light so that it's motion activated and you can go up there. Lighting to me feels like a very equitable solution, because at most cost levels you can afford that kind of thing, but it does provide a huge amount of impact. And I was going to say also the decluttering too, even though that's not really technology, but it sort of is, right? That affects your environment. That is what we do as clinicians. We're looking beyond products to solve our issues. We're layering everything up there and saying, hey, yes, a reminder for your pill is good, but also you really can't decrease falls if you have 10,000 things all over the floor and it's dark because you can't get up to the lights to get that done. So
absolutely.
Yeah, I think it's a big piece in there. All right, let's take another question here that I see. So people are kind of interested in this idea of like where to go to look for these products. I know, listen, this is an educational podcast. We're not going to be, highlighting all the things that all the best ideas and all this. But where would somebody learn about what products are out there? Do you have any suggestions for the listeners?
That's a good question. Again, I think we kind of touched on this a little bit earlier. Just AARP Age Tech is a great source for me. They actually have lots of products that come out there. You can join AARP even if you're not 50. And it's low cost or free. So I mean, I think that's a really nice solution or a place.
And you can go on LinkedIn and actually follow their feed, and you'll get all the new people that are inside of their accelerator, so that you could find potential ideas like that. Mm-hmm.
So I think that's one piece. If your state probably has some sort of age tech, some sort of like age, it might be called different in different places. We have Tech Owl here in Pennsylvania, so there's usually like a state-run technology lending library, or if you will. So I would look for that in your state. Again, in my experience, I found that sometimes it's more aging with a disability as opposed to aging into disability. So being able to parcel that out.
Yeah. And I've actually,
Conferences.
yeah.
So Carol and I do go to conferences that are outside of,
Yep.
our own profession. So I know the American Society on Aging has really ramped up. They have an on-tech section where they have some of
Yeah.
the technology on display that you can trial it. Also the Gerontological Society of America also has a whole tech hub. So these different, and also some state conferences. I think look for some of those low-cost places where you can kind of learn more about the technologies.
Yeah, and somebody actually had said one of the suggestions I was about to make, which is they were talking about any advice for working in inpatient rehab before patients get home. And I know I know a lot of inpatient rehabs that keep their own supply closet of, things that you could try before you get discharged. Maybe some of these DMEs, some of these tech enabled solutions. Is that something you guys have up there as well? Is that
So, that's a great question. We're working on a grant right now that was funded to us by the Department of Housing and Urban Development.
Mhm.
And we know that, traditional home modifications are great. And sometimes you don't want to like completely throw that out, but if you could just enhance some traditional home modifications with smart technology, you can make a bigger bang for your buck. So we were funded to really look at the older adult home modification program, which has been a great program that HUD has been funding in several different cities. And basically they allow you up to $5,000 per home to do home modifications. What we did was we took the allowable list. We looked for smart technologies that were out there and did the homework. We found about 80 products. We bought them all. We tested them in our house to see which ones work and don't work. We brought in occupational therapists, physical therapists, AT, tech providers, home remodelers to say, what did you like? What didn't you like? What was easy? What was bad? We brought older adults in to say what you liked, didn't like. And we created like a 15-item toolkit. And now we're actually building a training video of like where to look for these things, how can you use these things, and we're piloting it with some different agencies that some of you might even be partnered with. So some of our 8 partnerships are with some Rebuilding Together organizations, a Habitat for Humanity, and then also an independent agency that's doing home modifications here in Pennsylvania. So they're actually undergoing the training and then giving us feedback on the kit that we shared with them. And they're like, what do we do with the kit afterwards? We're like, it's yours, keep it. You can use it, you can put it there, because like we put it in people's homes. We're like, whatever you want to do. So we're trying to look at the just right sweet spot. We know that people need to touch these things to feel comfortable using them. So I do advocate, if you are in inpatient rehab too, to put in your budget. You don't have to buy everything at once. Buy a couple of items just to get the conversation going. And as a person who did work in inpatient setting in the past, one of the mistakes I made as a clinician was thinking if I really just was an amazing inpatient therapist, that my client would have all they needed when they went home. And that was a mistake. You cannot possibly know all of the encounters they're going to experience once they go home, even just fatigue. And so, even if it's only to entice them, and then maybe you have a partnership with the home care agency that they'll say, and you're like, hey, here, I'm going to show you these products, but, Joe, when he comes to see you as part of your home care, can actually help you install these in your home and use them in your home. So maybe being able to use it as a conduit to incentivize that person to continue their rehab journey once they do get home.
I love that. I love that. Those are all awesome. And so, right now, I just want to remind all the learners, all these unanswered questions are going to be included in the takeaway resource when the recorded version of this podcast launches. So don't worry. We will figure it out in there. So don't be sad if we didn't get to that question. There's just too much to talk about. I actually have one quick question that kind of relates to what I want to talk about next, which is where can I find all this cool research? Because what I love about what you're doing is that everything is backed by that. So is that accessible to us as clinicians? Can we Google Healthy Home Lab and research, and will it come up?
I guess I would start with we just relaunched our website because the tech was out of date. and because we wanted to make it more easily to use and friendly. So I think our lab is a good starting point. We don't have all of our articles or all of our research. We're still in process with some of our work. Even the grant that I just mentioned right now, we don't have all those pieces there, but they will be there. So come to our site and come back. My contact information is there. I would say also, just to give a plug as an educator, when you're affiliated with the university as a student or faculty, you have tremendous access to every research article in the world. But when you're a clinician, not so much, right? Yeah. So if you do take students as a clinician, I think a great project idea, and also as a thank you to you for taking on that student, is that student does have access to some of the research that talks about some of the solutions. So I think that that's a great way to show the full circle of an evidence-based practitioner and how to utilize your resources. So I know we don't always think of our student as a resource, and certainly we don't want to make them that the number one reason we're taking them, but they really do have that access, and that's a way for you to educate yourself. And let them know collegially that learning is a lifelong process. If we stop now, we're going to be stale and not give our clients the best that we have to offer.
100%. Always continuously learning. This is hugely valuable. I know there are going to be a lot of people wanting to ask more questions, kind of find out more about it. What is the best way for people to reach you, connect with you?
If you go to the Healthy Home Lab website, we do have a how to contact us. It is a Healthy Home Lab, I think, at pitt.edu. I don't quote me on it. Go to the site. And if you kind of put your question in there, we have sort of some pathways that everything eventually gets back to me. We're not that big that you can't reach me that way. But that's probably the easiest starting point.
Awesome.
We're always looking for collaborative opportunities. So if you have an idea for a product, you'd love to be involved in the lab, you'd love to be a resource to give us feedback on things, you can put that in your messages as well.
I think you will be getting an overloaded inbox very soon. Just be prepared, Pam, tomorrow morning. All right, guys. So huge thank you to Dr. Pam Toto from the Healthy Home Lab for sharing these incredible insights, practical takeaways on aging in place. And before we go, just a quick reminder that this episode is intended for educational purposes only, doesn't represent an endorsement of any specific company or product. We reference types of solutions, but they're really there to inform clinical decision-making and not to promote specific brands. Thanks for tuning into this episode, and I hope to see you all again next time. Bye-bye. Thanks for tuning in to Innovative Aging by MedBridge. Be sure to subscribe on Spotify, Apple, your favorite podcast platform, or listen directly at medbridge.com. If you'd like to earn continuing education credit and access bonus resources from this episode, just log in to your MedBridge account and search for the show title to get started. And we'd love to hear from you. If there's a topic you want us to explore or a guest you'd love to hear from, reach out via Instagram or email us at podcasts@medbridge.com. Thank you for the work you do and for joining us as we explore what it truly means to age in place. See you next time.